Thank you, and thank you to the organizers for this opportunity. I have nothing to disclose. So just to give a brief overview of what I'm going to talk about today, I'm going to start with some of the background information, just to kind of get us all on the same page. And then I'm going to talk about post-processing versus acquisition methods for doing this. And then I'm really going to go into the motivation for why we want to do this. And then I'm going to get to the real meat of the presentation, which is how do we balance the separate requirements for DSC and DCE, and then follow that up with some of the historical background and then more of the recent advances that we're all interested in. So perfusion imaging, often called dynamic susceptibility contrast, assesses the cerebral perfusion and other hemodynamic metrics. It involves the dynamic passage of contrast agent, shown in orange, and that induces a magnetic field perturbation, and so we observe this through space effect on a T2 star weighted signal. The most common metrics are cerebral blood volume, blood flow, and mean transit time. The applications are typically neuropathology, not all of them, but typically. So we're talking tumors, stroke, other vascular pathologies. My area of specialty is brain tumors, so that's kind of what I'm going to focus on, but that's by no means the only application. So we typically acquire a dynamic set of EPI images that can give us our T2 star weighted signal across time. When our bolus passes, we get a very nice signal drop on our T2 star weighted signal. We can convert that to delta R2 star, and that's how we get our cerebral blood volume. In practice, I'm showing that the contrast agent always remains intravascular. That is actually not what typically happens. So in brain tumors, we have a leaky blood-brain barrier, and so we get leakage of contrast agent into the extracellular, extravascular space, and that causes T1 effects, T1 shortening, and that's really the basis for dynamic contrast enhanced MRI. So DCE really assesses contrast agent extravasation. Again, it's a dynamic passage of contrast. So it's similar in that we're injecting like a gadolinium-based agent. This time we're looking at a T1 weighted signal, and the most common metrics are K-trans, VE, VP. There's always advanced metrics and advanced methods. Applications for this are a bit wider. It's non-neuro and neuro, cancer, cardiac, lung. There's a lot of different things you can do. This time we're not looking for a signal drop, we're looking for signal increase. And if we have a T1 map, we can convert that to a delta R1. Pharmacokinetic modeling, we can get the K-trans term or the VE, and this is a glioblastoma. So there's a lot of motivation for why you might want to do both of these, and so I feel like I would be remiss if I did not mention that people do try to do this on single echo data. From the title of my talk, I hope you can gather that we're going to be talking about multi-echo, but I thought I would mention that there are methods to try to do this single echo. There are a lot of drawbacks to this, and so I'm not going to focus on this at all. In fact, I'm going to just talk about acquisition-based methods. So a hypothetical workflow at Hospital X might be to acquire separate permeability and perfusion imaging. So you can have all of your pre-scans, your T1 weighted post, and do 2 separate injections. Advantages here is that your DCE and DCE can each be optimized individually, and also that the DSC can benefit from a preload from the DCE. We think that a better workflow would be to combine our permeability and perfusion into a single scan. So we can see right off the bat, we can reduce our scan time if we do this, and reduce our total dose. So if you can do this in a smart way with multiple echoes, you can combine these 2 echoes in a way that you get both a delta R2 star curve and a delta R1 curve. So a multi-echo method will allow you to separate those separate effects. I should note that they're inherently co-registered for DSC and DCE, so that's a real advantage. We still, of course, may have patient motion throughout the scan time, but the parameters are co-registered, and it's also a single injection. So why would we want to do this? I'm not going to talk a whole lot about this first one, but it is a motivation, concerns about GAD deposition. In the last few years, there have been reports that have shown that there is accumulation of GAD in the brain, even in patients with normal kidney function. Clinical implications of this are still unclear, but GAD dose reduction remains an important clinical target, and especially as we think about brain tumor patients or pediatric patients who are maybe getting surveillance scans every few months. And I will note that there's a plenary session on this later on this week if anybody's interested. So the next two that I'm really going to focus on are the ability to get better information, and what I mean by that is that both DSC and DCE can benefit from a multi-echo approach, and I'll show some specific examples of that. And then also the ability to get more information. So from a single scan, we can get perfusion and permeability. Those both can report on angiogenic processes in tumors, but they are not the same. They have complementary information. And we think that this really just gives us a stronger and more complete basis for our physiologic analysis. So to go more deeply into what I mean by better information, it's known that single echo approaches suffer from competing relaxation effects. So in DCE, we're typically talking about T2 star defacing effects as a potential source of bias. So in this paper, they showed that at a 4 millisecond echo time, they see the characteristic susceptibility-induced signal drop. So that's even at 4 milliseconds. And they also point out that once they convert using the two echoes to a delta R1 curve, that this curve looks different from either of the individual curves. And that indicates that even at 2 milliseconds, they're getting T2 star effects. And that's most obvious kind of in the first part of the uptake curve. Plenty of papers have shown the importance of multiple echoes for better quantification of the AIF in DCE MRI. So without T2 star correction, in this paper, they showed that they had pretty severe blunting of their AIF, where they were getting a very low peak concentration. And once they corrected for T2 star, they were able to get back to more of an AIF concentration. And that can be important for parameter estimation. The opposite is true in DSC MRI. So in DSC MRI, we really want the contrast agent to stay intravascular, but unfortunately, that doesn't always happen. So we have leakage effects. The most commonly reported effective leakage is T1. So even for a 26 millisecond echo time, we see that the post-bolus goes below 0, and that's a clear sign of T1 leakage effects. By doing a multi-echo approach, we can get rid of those T1 effects. In RCBV mapping, the cerebral blood volume, is related to the area under the curve. So you can imagine that if you have strong T1 effects, you can get severe underestimation in your RCBV. Multi-echo allows you to remove those, and so you get more physiological non-negative CBV values. I should note that we still have compartmentalization of the contrast of the contrast agent that leads to additional T2 star effects. But we showed in 2016 that by using a multi-echo approach to remove T1 and then subsequently correcting for the T2 star effects, we could get more accurate RCBV values as compared to a intravascular iron oxide agent. And we showed that in two rat brain tumor models. So moving away from better information and how we can get more information, by using multi-echoes, we can get a more comprehensive tumor assessment. So this is a high-grade glioma patient. This is a DSC acquisition with dual echo, and we get the CBV maps, CBF, mean transit time, and then we can also get our DCE-related parameters like K-trans and VE. The implications for this could be treatment or diagnosis. Here I'm just showing an example of how it could be useful for treatment. So in these separate studies, on the top it was a separate cohort that got single echo DSC. The bottom is a different cohort that got single echo DCE MRI. All of the patients were treated with bevacizumab, which is an anti-angiogenic agent. And in these two examples, they showed stratification of their patient populations based on their baseline RCBV and baseline K-trans. So you can imagine that if we had that information combined, we might be able to do even better and really determine which patients would most benefit from treatment with anti-angiogenics. So a question that always comes up is, do we really get the same information, the same answer when we do a multi-echo experiment compared to a single echo? So this was tested in 2012 in 2 rat glioma models with a single echo DCE experiment and then a dual echo DSC experiment. The animals were scanned several hours apart so that we don't get any confounding preload effects. But the potential caveat here is that relatively short DSC TEs and TRs were used. They still showed really high correlation between their DSC measured metrics and the DCE metrics for both K-trans and VE in both tumor models. And these tumor models really have different hemodynamic properties. So that was reassuring that we are getting the same information. So how do we actually do a DSC experiment or a DCE experiment if we're planning them individually? So thankfully, there have been some papers with various groups that have put out some standard recommendations. So for DCE, the recommendations are typically aimed to optimize T1 weighting, minimize your T2 star contribution. So typically you see very short TRs and very short TEs. The temporal resolution is not as strict in DCE MRI. In DSC, you typically want to optimize the T2 star weighting and minimize your T1 contribution. We also have the requirement for pretty fast temporal resolution. So we typically use an EPI sequence with a moderately long TR and longer TEs. So then the question is, how can we balance some of these recommendations that seem like they're not going to be balanceable to do this together and do them both well? And so the ones I'm going to focus on are the temporal resolution, readout, TR, and TE. So just going into more detail on these trade-offs, the first thing I typically think about is temporal resolution versus spatial resolution in our coverage. DSC typically uses EPI. It kind of gives us a good trade-off between our temporal resolution and our spatial resolution. The longer TR gives us enough brain coverage, so typically we use EPI. DSC, a lot of times we'll use single line method. It allows for the short TRs, short TEs to get that spatial and temporal coverage. But that's not enough. We can't just balance those two, so we also have to think about how do we want to do our DCE really well. So we know that we need enough T1 weighting to get concentration sensitivity. So this paper in 2008 showed how the concentration depends on some things we can't change, like the pre-contrast T1 and the relaxivities, and then things that we can change with pulse sequence parameters, so TR, TE, and flip angle. So for a typical DCE acquisition, you might be somewhere down here, which is enough sensitivity to characterize the tissue and perhaps enough to see the AIF as well. What we see when we go to more of a DSC style acquisition is that we fall off pretty quickly in our concentration sensitivity for delta R1. And so that can be problematic as we are looking at more like 1 second TRs. So not only do we have to balance the T1 weighting, but we also need the T2 star weighting for RCBV accuracy. So we showed in a paper that's been submitted and is going to be a poster this week. We used propagation of error analysis for RCBV to minimize the error in RCBV. And we found that the optimal echo time was 31 milliseconds for a tumor and 13 milliseconds for the AIF. So this just shows that even DSC could benefit from a multi-echo with that dynamic range of sensitivities. So we really want to be in that sweet spot right in the middle. And so we're going to take a look and see historically how have groups done this. So the earliest implementations, 2 abstracts presented at MRI meetings in the early 90s. Scanner technology was not what it is now, so these are single slice methods, and these are also single line readouts. Even so, they were able to get pretty good trade-off between their temporal resolution and their other scan parameters. In their first echo, they see pretty nice enhancement in their tumor, and even with 5-second temporal resolution, they were able to see a susceptibility-induced drop. Probably not enough, but pretty good for, I think, the early 90s. And what they said in the abstracts was just that you can get a lot more information and that this might have a lot of use. In 97, we see the first publication. In this case, they used a keyhole method to improve their temporal and spatial resolutions. Again, it's single slice, but they were able to get 2-second temporal resolution and really good in-plane resolution. And what they showed was that this might be useful for separating some different brain tumor types. And we also see an excellent example of why T2 star data needs to be corrected for T1 effects. The area under the curve is what determines your cerebral blood volume. So if you're just going to process this curve, you're going to get a negative RCBV, non-physiological. So we can see that we definitely need to correct for T1 effects. So now I'm going to go through some more of the older work, just to kind of give you a feel for what people have done. So still single line and single slice methods, but this time they use sliding window. So again, we've seen keyhole, and now we've seen sliding window to improve that temporal and spatial resolution. And this is just an example in a brain tumor patient. So we see elevated RCBV and CBF, and then we also see the corresponding K-trans, VE, and KEP. And then people have started looking at how can we make our DCE better with dual echo acquisitions, so better information for our DCE. And so I just want to highlight really quickly, we have our first 3D sequence, pretty terrible temporal resolution for the brain, but they're in breast. And they showed that T2 star compensation can improve signal intensity in CNR. We also see some interleaved acquisitions and multi-echo sequences with up to 6 echoes. In both of those cases, they were using the T2 star to get a better peak AIF concentration. So in this example, they showed that before they corrected for T2 star effects, they were at about max concentration of 5 millimolar, and once they corrected, it was almost double. And that's important for quantifying K-trans. So EPI-based sequence, so these are more DSC-style sequences. So we see that several groups started to look at how to remove T1 effects using multiple echoes. So one of the first examples is Permeate. So they have multiple echoes and then temporal enhancement with parallel imaging. So it's kind of a common theme to use some kind of acceleration. Multiple echoes improved their dynamic range and removed T1 contamination. So on the left side of the image is baseline, and the right side is bolus peak. We always see this characteristic drop due to the contrast agent, so that's perfectly normal. But what's problematic is in this slice down here, we see a lot of susceptibility-induced dropout. And that can be problematic when you go to quantify RCBV in those regions. So by doing multiple echoes, they were able to get back some of that information and quantify RCBV in those areas. I also want to point out that there may be a benefit for DSC in the AIF quantification, as shown in this paper. So I'm going to spend the last 10 minutes going over some of the more recent advances and where the field is kind of going now. So the first one is characterizing microstructure. So this is one of the first examples of really leveraging that information to come up with a new parameter. So we know that the concentration and R2 star relationship is determined by this little R2 star. This is notoriously difficult to measure. It varies between compartments, and it really depends on cellular geometry and vascular geometry. And so what they showed in 2009 and 2013 was that you could combine the T1 information to get CT and then plug that back in over here. solve for little r2 star. And so you can get some new information on microstructure. And so they showed that in a tumor. So you have a vascular R2 star and the extracellular little r2 star. And these provide complementary information. They're not just the same. So it really does vary between the compartments. Another paper came out in 2015 that looked at a similar little r2 star term. They did it at tracer equilibrium. That gets rid of some of the time dependence, excuse me. And they showed that it reflects cellular properties. So using simulations, they showed that their trait biomarker varies with cell volume fraction and cell size. So they basically say that it is a marker of cellularity, and they demonstrated that in a high-grade glioma patient. And it just is visually dissimilar from the other maps. And so it really provides some complementary information that we've never been able to access before. So the next recent advance would be finding ways to add even more information. So in 2012, this paper came out on a combined spin and gradient echo sequence. This is 2 gradient echoes, 2 asymmetric spin echo, and then a true spin echo. And this is repeated dynamically, so you can get fairly short TRs, so pretty good temporal resolution. And you can do this in brain tumor patients. You can quantify a lot of different parameters. So here we show, this is just the conventional anatomical images. We can look at gradient echo hemodynamic metrics. So we know from previous studies that gradient echo sequences are sensitive to total vasculature. We can also look at spin echo hemodynamic metrics. These are less sensitive to the total vasculature, and they're more sensitive to microvasculature, so you get rid of a lot of the large vessel blooming. If we combine that information, we can look at some vascular characteristics like vessel caliber. There's VAI, which is kind of a new metric that has been of interest lately in the DSC community. And it may relate to oxygen saturation and some other terms. So we can get maps of VAI. We can, of course, get K-trans, and then also these cellularity markers, the little R2 star trait terms. And so we showed that in a high-grade glioma patient. So one of the last things that I'll mention is spiral readouts. So we've only been talking really about Cartesian, so both EPI and single line, but plenty of people do non-Cartesian, and they might have some benefits for combining DSC and DCE MRI. Spiral readouts don't have the same geometric distortions and susceptibility-induced dropouts that we have with EPI. So for example, in this patient, this is a conventional EPI. It's not that they don't have any blood volume in this part of the brain, it's that the EPI had a lot of signal dropout and they weren't able to quantify RCBV up here. We see that with their spiral acquisition, they were able to quantify RCBV in that area. And so that's a real advantage. Spiral readouts also have higher readout efficiency and a shorter first echo time. So as we're thinking about a DCE experiment, typically you want that short echo time. And so if you can do a spiral out trajectory, you can really start your echo time at a very, very short echo time. And in this abstract, they also showed that there was no difference between their high-grade RCBV metrics between their spiral and their standard. Another advantage that may be shown with the advanced spiral sequence is the ability to overcome those issues with contrast agent sensitivity. So in this example provided by Laura Bell, also going to be the subject of a poster this week, she showed, in collaboration with Jim Pipe's lab at the Barrow Neurological, that 3D distributed spiral sequence was able to give her a higher Cmax than conventional EPI. So she did a simulation, so The red y-axis goes to a max of about 0.5 millimolar. Over here in blue, this is her 3D distributed spiral sequence, and the max is about 10, although it probably hits closer to 8 millimolar. So she got quite a gain in contrast agent max sensitivity. She also showed in a sponge phantom that she could vary her sensitivity from pretty strongly T1 weighted all the way down to a more T2 star weighted. And so she had several echo times ranging from short as 1.7 milliseconds all the way out to about 42. And so this might overcome some of those issues that we have. So the final advance that I want to talk about is one that we haven't seen any publications on yet, and I say yet because I'm sure that they are coming, and that's the use of multi-band methods, so simultaneous multi-slice. We've seen keyhole, we've seen sliding window, parallel imaging, and so groups are always thinking of ways that we can improve both spatial and temporal resolution. This is an example of a conventional single echo simultaneous multi-slice DSC experiment. In the standard case, they were able to get 11 slices. With SMS, they were able to double that for 22. They chose to double their spatial coverage, but one can imagine making some trade-offs between temporal resolution and spatial resolution to maybe improve both for combined DSC and DCE. They also showed excellent correlation between their SMS and the standard CBVs, and then they showed some examples in 3 subjects showing very nice correlation. I will note that there is a multi-echo SMS DSC talk tomorrow in the session New Perspectives in Diffusion and Perfusion Imaging. So if you're interested, you should check that out. And I think it's almost like a SAGE type SMS sequence with some interleaved acquisitions. So that could be really interesting. So I just want to conclude with some outstanding questions and point out that both DSC and DCE can benefit from multi-echo acquisitions. So even if you're not looking for more information, just the ability to get better information basically for free is always nice. And if we can get the added information for free, that would also be great. A remaining question is still AIF determination. It's not clear whether we should be using a DSC AIF, a DCE AIF, or a combination of the two, and how the different AIF characteristics might vary between the methods. The really big question that remains is how do we reconcile those conflicting demands? So what readout do we want to use? Cartesian, non-Cartesian, mostly I talked about single line versus EPI, but we can start thinking about doing spirals, distributed spirals, some really unique readouts. How are we going to optimize our pulse sequence parameters? So TR, TE, I didn't talk a lot about flip angle, but that's another one that we may want to optimize. And we really need to make sure we get enough T1 weighting for concentration sensitivity, and then also enough T2 star weighting for RCBV accuracy. So that's going to be a tough trade-off, but we're working on it. And then also, what methods could we use to increase our spatial and temporal resolution? So we've seen examples, keyhole, sliding window, parallel imaging, and multiband. So we will see what people can kind of put together to give us the best of all worlds. And then also, how do we still ensure that we have enough temporal resolution? DSC is pretty strict that you need under 1.5 seconds. Spatial resolution and slice coverage, you want to make sure you can see your tumor and you have enough resolution to do that. And then I didn't talk a lot about how to balance those to maintain SNR and CNR, but that's of course an important step to making sure that we have enough signal and contrast to get good parameters from our DSC and DCE. So I will just comment that this remains a challenge. It's going to take some technical developments, some ingenuity, and some careful thought about the appropriate trade-offs to make. But I think the future is bright for this field, and as I think we'll hear in the next 5 talks, it's probably full of echoes. So thank you all for your attention.